We're here at the CROI, and we're here with Sharon Walmsley, who's going to talk today on HIV/AIDS drugs and those in trials. She is from the HIV Canadian Trials Network and also the University Health Network. And we appreciate her taking the time because there's some new things, there's some things that are coming along. So give us the important information that people really need to know about HIV antivirals.
Sure, Fred. Well, I thought what we talk about today is sort of three things. First of all, should everybody just be on treatment now? And that's been an argument that many physicians have had over the years. If you have a virus, treat it. But we now have the evidence to support that, and I thought we'd talk about that today. The second thing is, over the past year, there's been a lot of changes in terms of antivirals that are available and what people are really choosing first line. So we talk about that. And then if we have a moment, we'll close with the end with what are some of the new drugs that are in clinical trials right now that will inform our treatment decisions for the next little while. So in terms of this whole when to start question, and this has been a debate in HIV from day one of HIV, is when should people start on treatment? And we've been really on a pendulum. When we didn't have any drugs, obviously nobody went on treatment. When we first got therapy, then people didn't get treatment until very late. And then we started to treat people earlier in disease, and then when the drugs had a lot of toxicity, then we started to defer again. So we've been on this pendulum. But at the IAS conference in Vancouver this year, we did have a presentation of the START trial, which is a randomized controlled trial which now has addressed this question. And what this START study was, it was an international trial. It involved almost 5,000 participants. And these were individuals who had not been on therapy and were randomized either to get it right away or to wait until their T count dropped to the 350 range, which really was the treatment guidelines at the time and what most clinicians were doing. So the immediate ART went on right away. The deferred waited until their T count dropped to about 350. Although this study was planned to go on much longer, it was closed by the Data and Safety Monitoring Board, and that always happens when there's a clinical trial. There's a special board that's independent of the trial that is watching the results as the trial goes along, and if they feel that there is an advantage of being in one treatment arm over the other, then they will stop the study, and that's what happened.
Because this trial is controlled in a way that no one knows except for that group.
Right, so it's a placebo-controlled trial, so people don't know if they're getting active drug or not. So you can see from this slide what really happened, and so the people in blue are the people who got their HIV treatment right away, and the people in red are the ones who deferred. And what was interesting is not only were HIV-related events decreased in the group that got treatment right away, but these so-called non-AIDS-related events, heart disease, cancer, kidney disease, other problems, they were also decreased. And as you can see from the graph, it's almost 50% how much it's been decreased, both AIDS-related and non-AIDS-related. And if we look in terms of some of the non-AIDS-related events, it was cancer and it was heart disease. So this is really a big study now that has changed practice, and what most physicians feel now is if you have HIV, you treat it. That doesn't mean it's an emergency, okay? And that doesn't mean that somebody has to go on treatment the first day they walk into a clinic or got newly diagnosed. Obviously, people need to be prepared and they need to get their things in order to start therapy, making sure they have the appropriate coverage and access to drugs and are able to follow up and are mentally and physically prepared to start treatment, because that's really crucial to getting started on treatment.
But it really speaks to also the fact that we really need to consider more people being tested.
That's right.
Because if you don't know you're positive, you're not going to know the advantage that you're going to have. You're not going to be aware of the advantage that you have to get on treatment early.
That's right.
It may be, in fact, that's one of the worries that we had down in Florida many years ago, when women would be unsuspecting that they were in a risk category.
Right.
And they would be detected when they had some really serious opportunistic infections,
right,
as many people were.
And presented very late. And it's not to say that treatment won't work.
But it's just
when you're
so
late.
much better.
But it's so much better that if you can start treatment early. And this is the argument now, because I think we used to have this period with our patients and saying, well, we're not quite sure if you need to start treatment yet. And then there tended to be this real hesitation. And then finally, the day that came, it was time to start treatment. That was very traumatic. And so I think that's taken a lot of that.
It was second only to the being diagnosed.
Exactly.
Yeah.
So this has taken away a lot of that. People come in, it's now recommended that you start on treatment. Here's what we're going to do to get you ready for treatment. And so you don't have to go through that phase now of, well, is it time yet? Is it not time yet? So I think that's...
and it's also good for the community viral load.
Right, absolutely, absolutely. So in terms of the drugs that we have, and I think much of your audience is going to be familiar with these, we currently have 4 classes of drugs that are the main ones that are being used in treatment of HIV at this time. We have those things called nucleoside reverse transcriptase inhibitors, and everybody just kind of calls those the nukes. And that's not to say that we're not kind of having an atom bomb here, but we call them nukes. Some people also call this backbone, so that's another term that people might have heard. We have drugs called the non-nucleoside reverse transcriptase inhibitors, and then we have the protease inhibitors, and the protease inhibitors usually have to be what we call boosted. And so this is giving another drug along with the protease inhibitor to make the level of the drug higher. And in the past, the only booster we had was a drug called ritonavir, which is in itself a protease inhibitor, but now we have a second booster called cobicistat, so that's something new.
It makes the drug stay in the body longer and be more efficacious without having to take a lot of that drug.
That's right. And so what it does is it allows you to take fewer pills at longer intervals, and they're more forgiving in terms of the timing, whereas in the bad old days, everybody used to have their watch and to take things every 8 hours and whatever. But important thing is, we all talk about this boosting, and so often when patients end up in hospital, they'll say, I'm on boosted darunavir, and sometimes the resident or the intern or somebody on board doesn't understand what that means. So it's really important to understand that there's a drug, either ritonavir or cobicistat, that's part of that combination, because if that booster gets left out when they go to hospital or have a problem or see a new doctor, that can really be a problem.
And that boosting effect also may be boosting another drug that they're taking other than for HIV.
And that's the other crucial part.
So having a good pharmacist that knows HIV and knows the boosting effect and knows the other agents that the other drugs that might be affected by that is important.
Absolutely. And so we always tell our people, if somebody's going to start you on something new, talk to us, talk to the pharmacy, talk to someone to make sure that there isn't an interaction, which is either going to make one drug too high and can cause toxicity, or too low and then not have your HIV.
And they may be able to regulate the amount of the other drug. Yeah.
That's right. That's right. So what are the sort of the key things about treatment now? So we now know that you need 3 drugs to optimally suppress your virus. When we used 1, resistance happened in about 6 months. When we used 2, resistance happened in about a year. With 3, you completely can get the virus under control. And if the virus is under control, then resistance doesn't occur.
And you can stay on that drug for a very long time.
I've had people stay on the same thing for a decade or more. You can, as long as you're consistent with it. 4 doesn't do anything more. So 4, 5, whatever, doesn't seem to add anything but cost and toxicity. So 3 is the magic number when you start therapy. Now, when people have had resistance and need new combinations, sometimes they have to take a little bit more.
Or you might have this where you could start a drug or start a multiple combination, then drop out a drug just to get to a level at some point. I mean, that's a finesse.
An approach. That's an approach.
Some sort of finesse.
Yeah.
A good doctor might know
Yes.
to do that, but
yeah. Sometimes that happens. Sometimes if someone is very ill when they present and the viral load is very high, they can't get the resistance test right away, so they don't know what the best line of therapy will be. They will put more than 3 classes of drugs, get the virus under control, and then back some off.
Right.
Yeah. So the other key is it's only as good as you take it. So if you don't swallow it, it don't work. And so that's really key, is being as good as people can to taking their medications every single day. And if you do, and you get the virus under control, then resistance won't happen. And as you alluded to, that can last for a decade or more, which is fantastic.
So having this relationship with the same doctor is good because the doctor gets to know you and you know get the doctor.
Absolutely.
And you get to the point where you can say, well, the doctor says, well, I don't know if they're going to take this.
Yeah.
This is because this is going to cause this kind of stomach distress, or you've had this before and you don't remember it. So you having that relationship with the patient makes it so you can work with them a little better. So staying with the same doctor is not a bad idea.
Not a bad idea. And that dialogue is important. And having that relationship so you can say, I can't take this because this, that, and the other thing, or I missed this, so that your doctor can understand what's going on with your therapy. Because the next point is taking part of it is the worst thing.
Right.
Okay? That's worse than taking none or taking all. So taking a part of it, that is a situation which really allows the virus to get resistant, which can mess up not only the treatment that you're on right now, but can also mess up treatment options for the future. So what I always say to patients, and it happens all the time, we're human. People go away, they forget their pills, or they don't have enough money, and they start taking half of it in order to spread it out. That's the worst thing to do. Be honest with your doctor. If you can't take it all, it's better to stop it and then work out a situation to get back on rather than take part of it over time. So that's an important message.
There's only, I guess, is it still one drug like efavirenz, which is still being used, that has a long tail, and it will create some resistance if you stop taking it. There's this drug combo that they can put you on to get you off of of that. But most people aren't going off treatment.
Most people that start treatment now pretty
will be on it forever.
Stay on
At
treatment.
least until we find a cure.
Unless we get that cure, yeah. So the other thing is switching, and lots of switching goes on in practice, and switching goes on to make it easier, to make it less toxic and whatever. Switching is safe if the virus is under control, but it's really important that if you're going to switch, that your doctor does understand what you've been on in the past and if any resistance has happened, because you've got to be careful about switching that you don't lose the virologic control. So back to your point about keeping your doctor and having that dialogue, or at least keeping a record of what medications you've been on over time, and if they haven't worked, or you've had toxicity, or you got resistance, having that information so that if somebody has to make a new combination for you, they can understand what happened in the past.
Are you a physician that treats in a way that you would suggest, or you would initiate a discussion with the patient about switching, having no other, just because there's a new drug, maybe with single pill, whatever, or do you say, well, if it ain't broke, don't fix it?
If it ain't broke, don't fix it, but sometimes it is broke. And sometimes it is broke, and the patient may not feel abnormal and not understand that it's broke, but it's things that we might pick up on the blood tests that suggest that there may be some organ damage, or we might predict that for you, this particular drug may have this complication in the future if you keep on this drug. So even though it's not broke now, it might be broke in the future.
Cardiovascular issues and so forth.
Kidney issues, cardiovascular issues, bone issues, yes. And as my patients are aging with me, a lot of these complications of HIV are coming along as people get older, and there may be a need to switch medications as patients get older to have less impact on their organs.
We just had a conversation like this with an individual from Australia on malignancies, and then also the DAD study, which of course highlights all of those things that you might consider, you just mentioned. So those are to take into consideration.
Right. Okay, so as you alluded to, everybody now wants the one pill once a day. And certainly when people start medication now, most people choose a one pill once a day option. It's easy, it's simple, whatever. And for patients, taking only one pill makes them feel less sick. Maybe only one pill, it's easier to handle and easier to get your head around than all of the tablets we used to take in the past.
Yeah, I think it is. I think that it's psychological, but it's real.
Yeah, it's real. But again, this is for people starting treatment. And of course, many of the patients who come into my office have been with me for many years and have had lots of resistance over time. The one pill once a day is not for everybody. They are for people starting first-line therapy. So there are 4 different ones that we have that are available in North America now. They may not be available all throughout the world. 2 of them are based on an NRTI-based regimen, so efavirenz or rilpivirine, and 2 of them are based upon an integrase inhibitor, either elvitegravir or dolutegravir. And then in these combinations, then the backbone differs, with 3 of them having 3-TC and tenofovir, and then the last one having abacavir and 3-TC. So really, when somebody comes into the office, I mean, this is usually the shopping list, and there can be some decision around, which one of these combinations is a patient going to take. And they're all 1 pill once a day. And so really the choice comes down to what are the different side effects associated with these particular combinations. Does the patient have any resistance before they start on therapy, which may lead you to choose one over another? And then again, do they have any cardiovascular risk or kidney risk, which may influence the backbone of the combination that you're wanting to take? So those are some of the decision-making processes that go through. The only other decision-making process here is that Complera needs food in order to be absorbed. And so that's a drug that requires at least 500 calories with every dose of the drug, and not everybody likes to take that kind of calories, so you have to watch that. With the elvitegravir, it is an integrase inhibitor that needs to be boosted, so it has all those same problems as ritonavir as a booster in terms of drug interaction. So that's a consideration that you would want to make before choosing that.
Yeah.
So if we go, now there are these so-called guidelines that are being made throughout the world. These are the ones that are developed by the United States. And as you can see, the major shift in the guidelines over this year is that it's primarily these integrase-based regimens that are now recommended as first-line treatment. There's a boosted protease inhibitor that's been left on the line, but the NRTIs, which were always our go-to drugs, efavirenz and atripla has been our go-to drug for the last decade, has now been relegated to the alternative category. So we kind of did this. So why? This was always my drug.
Yeah.
Somebody come in the door, it was atripla to something else.
Unless you had dreams or something,
Yeah.
you were good to go with it.
Well, and I think that's the issue, is so that in terms of working, this is a great drug. It works at high viral loads and low viral loads in old men, young women, it works in everybody. But that was the problem, and the main problem was the CNS side effects, which causes the buzzy dreams when people go to sleep, or some great dreams, some people say. But that's the whole issue, is that for efficacy, it's fantastic, but in terms of tolerability, some of our newer drugs and some of these newer single tablet regimens are doing much better in terms of side effects for patients. And so, in the past, when we didn't have any options, we made you put up with that. Okay, yeah, you have a few dreams, but whatever, take it at bedtime, have a sleeping pill, you'll be fine. But now, if you have an option of taking something that's not going to cause all of those problems, that's why the guidelines are changing.
And that's the way the studies ran. I mean, they were all against the gold standards.
Absolutely.
The new drug versus the gold standard.
Absolutely, and so that's what I've shown on here is that first of all, it was in START Merck where the comparison was raltegravir. Then there was the single study when it was compared to dolutegravir. There was the STAR study when it was compared to rilpivirine, and the Gilead 102 study where it was compared to elvitegravir. So in each of these trials, in terms of working, in terms of getting the virus under control and bringing the T count up, everything was the same. But the side effects from all these other drugs were lower than that of efavirenz in all these studies. So that's the reason for the change. So we really come into what we're calling the integrase inhibitor era, okay? And so there are 3, raltegravir, elvitegravir, and dolutegravir. And I think we've kind of talked about already in terms of which one you choose. And so part of the decision-making process is what is it combined with? Do you have to worry about food? And do you have to worry about boosting or the drug interaction? So that's really how we sort that out. And I alluded to already in terms of the fact that these things work fantastic. And in the clinical trials, we're having 90% of people having suppressed viral loads. And we just never saw those kinds of response rates before. And these are very well tolerated. So they're better tolerated than the boosted protease inhibitors. When you look in the trials, hardly anybody has to stop them because of side effects. Their lipid profile and therefore their potential cardiovascular risk is much, much better. And there are a few tiny side effect symptoms that have been described that you need to think about for your patient, but they don't happen very often. So that when we look at these major trials of the integrase inhibitors, you can see that only 1 or 2% of patients ever had to stop in the trials because of this, and that's really incredible. And I think that's the huge advance we've had in treatment in the last year or two.
And this is the message to
Yeah.
the people, why to get tested. The old days, people said, I don't want to get tested, there's no drugs.
Yeah.
Okay, well, that's understandable.
Sure.
But now there are not only drugs, but there are drugs which are, I won't say innocuous, but they're almost.
Absolutely.
They're just very tolerable.
Right.
And so there's all the reason in the world to be tested, because if you want to be if you want to be healthy,
Yep.
ongoing for a number of years,
Right.
you get on the treatment, you take drugs that aren't going to be damaging to you and are going to help you stay alive and healthy.
Absolutely, absolutely. And you're right, and that was part of the argument. I don't want to start drugs now. I feel fine. I don't want to take something that's going to make me sick. But now, you can take 1 pill a day, and it's not going to make you feel sick. Yeah, it's a very strong message.
The only thing I worry about is adherence, because like you said before, it is very important to take the drug. So I can't get done saying that enough, and I think a lot of people say, oh, I don't want to hear another adherence message. Well, if you're not adherent, it's important that you be.
Yep.
There's no question
Absolutely.
that the drugs it will not work.
That's
they
right.
will be deleterious
Yep.
if you don't take them
Yep.
the way they're supposed to be taken.
Yeah, and that was my message before. Taking
Yeah.
part of it is the worst scenario, and if you're not there, you're better not to take them than to take part of it. That's a really important message. That's a really important message. So what about the backbone? So we referred to before, there's really only 2 backbones that people are using now. And again, the choice, they both work. The choice is related to the possible side effects. So tenofovir very rarely can cause disease of the kidneys, and with age can cause disease of the bone. On the other hand, abacavir has been linked, although it's controversial, to heart disease. So if somebody has a high risk for heart disease, then that may be the other choice. So most physicians will use one of these 2 backbones when we're treating today. But there may be some new things on the line, and this is a drug that we're going to expect to see over the next year or so, which is the prodrug of tenofovir. So rather than concentrating in the blood, this drug then concentrates in the cells. So with less drug in the blood, the hope is you're going to have less kidney and less bone toxicity over time. And some of the early trials have supported that, although the trials are early and we don't know the true clinical benefit of it. This may be an advantage to this new form of tenofovir, and we call it TAF, is the word that we use to make it easy. What else is coming? So a protease inhibitor now is going to be a new single tablet regimen. So they're putting all this stuff together, so darunavir or atazanavir with the booster cobicistat and that TAF drug, tenofovir and FTC, all in one tablet. So clinical trials are going on with single tablet regimens, but with protease inhibitors, so these will be the first ones on the horizon.
And these are pharmaceutical companies working with each other to create this. Yeah.
That's right. And so we have a number of other agents that are in development to try and develop agents in the classes that we use right now to have less toxicity. Again, new formulations to allow the drugs to last longer. And then there are some people that need new drugs. So there are some drugs in the so-called attachment inhibitor family which prevent the HIV from getting in the cell in the first place. And there are maturation inhibitors, which are drugs preventing the HIV from completing its replication cycle. So this is some of the stuff we're going to hear at CROI this week, and some of the new drugs that are still in clinical development but may be available for patients down the pipeline.
And we have a number of doctors who are going to be talking specific to the work that's been presented.
Right. And then the last thing I wanted to talk about is just some new approaches that are coming down the pipeline. And so one is, do we always choose the right dose of drug?
Yeah, I'm a big one for that.
There's a lot of
back
people-
many years ago was talking about TDM
Yep.
and so forth. Yeah.
Yep, and so the first one was in efavirenz, and there was a study called Encore, and they used lower doses of efavirenz that worked just fine. So that's an option. The other things are more and more of these combination tablets so that people don't have to take so many. And then people are looking more and more towards these long-term treatment options, which will either be oral or injectable.
Or both.
Or
because-
both?
Well, they have to be, I guess, to get, in some cases, I mean, they're going to be tested out
Right.
in the research as oral, and then they move them to the
That's right.
injectable, because you don't want to have something in your body you can't get rid of.
That's right,
So,
that's right.
but they seem to be
Yeah.
doing pretty well.
And again, you know, they're not for everybody, and they're not going to solve adherence problems, you know, and people who don't like to take their drugs all the time, these could still be a problem because
So
you
the-
need to be adherent to these too.
So this could be the person who has mental problems that isn't always rational, or
Right.
and this leaches out of into their blood
Right.
very slowly, just at adequate doses, and
Absolutely.
and it could be the perfect thing for some
Yeah.
people.
And not necessarily somebody with any problems. Maybe somebody who just prefers
Busy.
to do it. Busy, does it once a month or once every 3 months and has it over with. Kind of like ladies in their osteoporosis now treatment. You know, there's an injection they take once a year. Well, if we can get down to that, it'd be very simple to treat HIV. That's a little ways
I'd
down.
almost feel like it was cured.
Yeah, well,
Point.
that's a long way away. But anyway, that's kind of some of the ideas on the horizon. So I think the main messages are today is if you have HIV, there's clear advantages to going on to treatment. Treatment has gotten easier and better and more tolerable over time. But as you and I keep reinforcing, it's only as good as the person that takes it, and you have to take it all the time. The integrase inhibitors are clearly now the drugs that we sort of go to in terms of first-line therapy. There are some different members in the family, and we talked about some of the reasons for choosing one over the other, but that's where most patients are getting started on treatment now.
Thank you so much for being here, Sharon.
Okay.
It's been very helpful. I know that you've really covered it very broadly and very effectively. I think you did a great job.
Fantastic.
Thank you.
Always a pleasure. Thank you.
you.